Okay, I think we'll get started. Welcome, and it's my great pleasure to kick off our NAO Lecture series for the year with an incredible panel. And I'm delighted to be here. I'm Sarah Allen, Director of the North American Observatory on Health Systems and Policies and Associate Professor at the Institute of Health Policy Management and Evaluation. And the North American Observatory on Health Systems and Policies is very much a network, a center that relies heavily on partnerships and networks of scholars and professionals across North America, and in close partnership with the European Observatory on Health Systems and Policies. And so this couldn't be a better way to start our series, to have this incredible panel from two of our very close partners and collaborators from the United States and the UK. I'll first turn it over to Monica to just run over sort of how this session is going to work today.
Thanks, Sarah, and welcome everyone. I'm Monica Roig, the Research Coordinator at the North American Observatory. So like our other NAO lectures, which has been a little bit of time, well, we do reserve some time at the end for questions, and we welcome you to make use of the chat box. Or if you want to raise your hand, go on screen and unmute yourself, you can ask a question directly as well. Sarah will be moderating the discussion period. And today's session will be recorded and posted onto our YouTube channel. That usually occurs within 1 week, so keep an eye out for that. And you can also email the North American Observatory for any updates and if you want to join our newsletter. And the question period will be omitted from the published recording. So feel free to ask all the questions that you want within our time.
Thanks, Monica. So I'm going to introduce our speakers for today, and then I'll turn it over to them for the lecture component of the session. And as Monica said, there will be lots of time for questions after. So think about them now, post them in the chat when you have them, and we'll have a chance to discuss after. But it's really my great pleasure to introduce our two speakers. LYNN UNRUH is a PhD and registered nurse who's a professor of health services administration at the University of Central Florida. She worked as a nurse for 27 years and then received a PhD in economics. And she currently researches issues of healthcare supply and health policy in general, and was co-author of 3 editions of the Economics of Health Reconsidered and 2 editions of the United States Health Systems in Review, Health Systems and Transition series. And we are, NAO is very pleased to have published all North American countries in the last 2 years. In 2012, LYNN became a representative of the US for the Health Systems Policy Monitor, which is a network that the European Observatory on Health Systems and Policies runs, and of which NAO is a member, which facilitates the type of comparative policy research that we all enjoy. And in 2020, she also became a representative for the COVID Health Systems Response Monitor, again, run by the European Observatory. And so is very well placed to speak to the pandemic response in the United States today. Our second speaker, Gemma Williams, is a research fellow and member of the European Observatory on Health Systems and Policies London Hub, based at the London School of Economics and Political Science. And she conducts comparative health system research focused on the workforce, health financing policies, health inequities. And her work on his topics has covered a number of regions, including the UK, but also across Africa, Asia, and North America. She's the author on several observatory studies, rapid responses for the state of health in the EU program, as well as covering health systems and policy developments in Cyprus, Ireland, and the United Kingdom. She's worked closely on editing the EuroHealth, which is the European Observatory's quarterly journal, and has, prior to joining the observatory, worked as a health economist in the Rwandan Ministry of Health. And so we're absolutely delighted to have two experts come and join us to share their overview of the pandemic response in a short time, but we'll be able to address some of our burning questions after. And to kick it off, we will start with our closest neighbor, the United States, and Lynn will have her 10 to 15 minutes now. Thanks, Lynn. Over to you.
Okay. Thank you, Sarah, Monica, Gemma, and all our participants today. I'm very happy to be here. I'm going to try to get this going. Oh, and it's delayed. So, of course, I went way too far. And I'm going in the wrong direction. Okay, I'm going to talk about U.S. experiences and lessons. One of the first things we want to do is just let you know what's been happening with the virus, cases, hospitalizations, et cetera. And so in the US, you'll typically see this in all the other countries too, and in the UK responses that we've had several surges of the virus over time. This here is the initial surge, and this is Delta, and now we have Omicron. And Omicron has had the most cases, but a little bit less virulence. So the hospitalizations and deaths per case are much less, but because it has been so, the transmissibility has been so high, we've still had a number of hospitalizations with Omicron and a number of deaths, and the deaths lag. So we're waiting to see what the outcome of the surge has been over the past couple months with Omicron. And so the death rate is still pretty high in the US. We have, as of January 31st, the statistics were 74.3 million cases, which were in the hundreds of thousands per million population, and a large number of deaths. I fear that we will hit 1 million or over deaths before we're petering out on this COVID virus. And it is just, we've had phenomenal number of deaths. And in the US, we're 4% of the global population, but 15% of deaths. So proportionally, we've had a high proportion of cases, hospitalizations, and deaths. And found this interesting statistic: we are 3 times higher than Canada in terms of everything. And I want to attribute the New York Times and Our World in Data for a lot of this. It's they've been doing phenomenal work in posting these on a daily basis. I think I probably hit it too many times. There's just a real lag. Maybe not. Let's see if I can get it. And it seems to have frozen on me. Let me try this. I'm stuck. Oh, I think this is where I'm at now. I don't know. I have too light a touch with my finger, possibly, but it's hard to relate our response because there's been 2 years of it now. So I just divided it up into what happened in the first year and what happened in the second year, going into close to the third year. In the first year, the US and many other countries that were in the HSRM that we were reporting our response to, this is typical that we were not very prepared in terms of our public health system and our healthcare systems. For the US, this is the first time we've really had a bad pandemic, certainly in my lifetime, whereas some other countries in the world we sort of managed to evade some of those other pandemics that were going around. So we had our public health service was not in good shape. Our healthcare systems weren't in good shape. We definitely were not aided by the fact that we delayed our stay-at-home mandate. Not by much, but by, say, a week or so. And it was enough to have the virus explode everywhere. We had trouble with initial testing. We didn't have tests that were right at the beginning. And then getting the tests out, getting reporting done on a quick basis was all problematic in the first year. And then as the number of cases started to decline, pretty soon, after a couple months, everybody was ready to open up. And the several states, particularly in the South, where the governments are more, the governors and the state legislators are a little more conservative. They went ahead and opened up before we had adequate testing going on, before the case loads were down enough. And so this was around May of 2020. Then following that, there was failure to mandate and force mask wearing and social distancing, which can be done even if you open up your economy and you're not staying at home anymore. But many states took the view of, we don't need this stuff, we're not going to do it. And as a result, as the year 2020 wore on, we had periods of hospital surge over capacity. We had a beginning workforce stress, because at the beginning of all this, everyone in the workforce pretty much felt, well, we'll rally around being able to handle this, we'll do heroic efforts, and then it'll all be over with in a few months. But as we can see, that was not happening. And these two bullets are at the bottom: lack of scientific unified governance and politicizing of policies. But really, they should be kind of at the head, because if these had been better managed, everything else would have probably flowed a little bit better. And that in particular, going into the second year, and this I divided up and showed a little bit more specifically. In terms of preventing transmission, we did get our testing capacity up and going, and our testing is much improved. And with the, we both have the tests that take several days, and we have the rapid tests that are now at home. So we've had some trouble with Omicron in terms of not running out of the rapid tests, because it's just such a surge in cases. But still, it's going pretty good. Where we have fallen down is in maintaining state mandates or reinstituting state mandates for mask wearing or social distancing when we have surges. And there was a surge with the Delta virus where we really should have had more mask mandates. No federal masking mandates since sometime in 2020. And state mandates are very, very few, as I'll show in the next slide. And then also vaccinations, which we thought would be the salvation. We're not horrible, but we're at 63.5% fully vaccinated, and we could be much better. We've had a lot of, I wouldn't say people I call it hesitancy. People are hesitant to get it, people who are pregnant, other, health issues they might have. But then there's the opposition, the full-blown opposition, which does tend to take a political stance. And then there's been a lot of controversy over mandates, which I've been chuckling over the Ottawa problems in Canada as of late, because apparently there's a similar issue in Canada. This is the little map of where we do have mask mandates. This was as of January 19th, 2022. You can see that I counted them up. If you count these, there's 11 states that are mandating masks to some degree or the other. And all the rest of our 50 states are maskless. No mask mandates. In fact, in Florida, where I live, there's an anti-mask mandate. We cannot mandate masks, and I work in the state school system, so I cannot mandate that my students wear masks. And we've been mandated to go back to class. So there you go. A little bit more on the second year. I know I'm running out of time. Because of all of this, the surges, we've had some hospital surge over capacity. We've had work overload and unsafe staffing and risk of disease. And then we've had the workforce is now responding. After 2 years of this, people are burned out, mentally exhausted. They just cannot do it anymore. And so they're starting to leave. And this is very, very, very scary. And this was a paper that was done in the end of 2021. I see someone quit every day. Bedside nursing is no longer sustainable for me, etc. This is the worst nursing shortage that I've witnessed in my career. And so things are looking not too good as far as the workforce goes and for the future. Again, same governance issues as in 2021, lack of scientific unified governance. And what was coming out more in 2021, we have a new administration, we have a Democratic president, we have control of some of our Congress, and you would think that there would be better public health guidance, et cetera. But and in general there has, but there's been some bizarre things coming out of the CDC. One in May of 2021, where they said that people who are vaccinated don't need to wear masks, with no real scientific evidence. And as it turns out, even if with vaccinations, you still can get it. You might not get it as worse, you might not be hospitalized, but you can get it and spread it. So it was somewhat of an unwise decision. And then a second one recently, lowering the length of quarantining to 5 days, initially with not even a need to get a negative test before you come out. Again, not necessarily a very wise decision. And some believe that these decisions were made with some pushing on the part of economic, like Delta, for example. Delta Airlines wanted to not have to have the 10-day quarantine so they could get their staff back on the airplanes. And so there's been some talk of that. And then a continued problem with public health policies varying from state to state, a continued politicizing of policies, anti-mask and vaccine sentiment, still a lot of it out there and still related to political outlook. And really, we're becoming a very divided society over how to respond to this and many other things. Is sort of all coalescing. And so finally, I'm going to skip over this, but it's wonderful. I worked on it some more, and it shows the link between, it attempts to show the link between the virus, the policy and public health actors, and where we're at in terms of our morbidity, mortality, and length of the pandemic. Our lessons, what I am drawing from them, these are mine from what I can see of what I've read in research papers and observed and monitored myself, that we need better public health and health system preparation and infrastructure prior to the pandemic. One of the things that came out recently was a New York Times video of nurses. And the quote at the bottom is from that video, that the healthcare system was already broken. COVID only made it worse. We were not prepared. And second bullet, public health decisions based on the strongest scientific evidence possible. Try not to have that influence from politics or economics. Third, nonpartisan political leadership that lets public health take the lead. And fourth, stronger federal leadership, which I think we're going to talk about in a bit. So take it away, Gemma.
Thank you so much, Lynn, for that succinct but compelling overview of the experience in the US. And I'm pleased to turn it over to Gemma to share her talk on the UK experience with a focus on England. Thank you.
Well, thank you very much, Sarah, both for the introduction and the invite to speak today about UK experiences during the pandemic. And also thank you to Lynn. I think that was a really great presentation, and it's interesting to see that many of the challenges that the US has faced, I think the UK has also faced. And I think I would also highlight that sort of last quotes that we just saw is a very key one, that many of the issues that we've sort of seen in health systems during COVID, we already knew were problems, and COVID has just sort of really shone a spotlight on them. So before Well, let's see if I can get the screen to move here. There might be a lag again. There we go. Before I jump on to talk about the UK experiences during COVID, I just want to sort of pause and talk about some aspects of the UK that are sort of might be unfamiliar to most of you, but are quite important to understand our COVID response. So the first thing is the UK is actually a multi-state nation. So we have 4 countries, constituent countries: Scotland, England, Northern Ireland, Wales. And we have a devolved rather than federal system of government that we have, for example, in the US. And while some sort of issues and areas such as economic policy, foreign policy are sort of a UK-wide issue and the responsibility of the UK government, healthcare and social policy are actually devolved issues, and responsibility for them rests with the devolved governments in Scotland, Northern Ireland, and Wales. England actually doesn't have its own devolved government, so everything is the responsibility of the UK government. All countries have a national health service, which is taxpayer funded and provides universal coverage. And each country has its own public health agency. So, and in the grey box, just some key issues related to the COVID-19 response. So initially, sort of for the first 4 months or so, there was a 4 nations approach to dealing with COVID-19. And this meant that all public health measures were sort of implemented at the same time, following a sort of consultative joint decision-making process. However, in May 2020, approaches started to diverge because the devolved nations thought that the UK government were lifting restrictions too quickly in England, so they kept theirs in place for longer. And then for the last sort of year and a half of the pandemic, restrictions have been put in place at slightly different times and have diverged slightly between the countries. We have a scientific advisory group for emergencies. This is comprised of sort of various technical experts, scientific experts that are responsible for analysing data and giving scientific advice to all nations. However, it's the responsibility of the government in each country to sort of interpret that evidence and make political decisions on that basis and taking into account other factors. So just looking quickly at the UK cases, deaths and vaccination coverage. So the UK actually has among the highest number of confirmed COVID-19 cases in the world. So on the left in the figure, you can see the sort of 7-day rolling average of new confirmed cases. And like Lynn has already explained, has sort of followed the waves of Delta, the Omicron is sort of the most recent and highest peak. Relative to population, the UK has actually seen a higher number of cases compared to the US. It's had, I think, 2 times the number of cases of Germany, 3 times those in Canada. However, we need to sort of interpret this carefully because this obviously reflects testing capacity. And at the moment, the UK has one of the highest testing capacities in the world. Then in terms of deaths, deaths are also might have been all the way through sort of among the highest in the world, really. Slightly on a population basis, less than the US, but more than the EU, sort of 2.5 times that you see in Canada. Again, there is the issue of interpretation and comparability that COVID deaths sort of vary between countries, the definition, and it might be too strict in the UK. That's sort of a criticism that we have faced. And also just to highlight, there's been huge inequalities within the UK. So the poor, deprived communities and certain ethnic minorities have seen higher death rates and higher cases than many other population groups. So in terms, and actually as well, I should highlight that the vaccination program, however, has been a really notable area of success. There's only a few countries that are sort of doing better in terms of the percentage of the population covered. And when we look at sort of the figure on the right, we're doing really well with the boosters, the 3rd doses. So almost 65% of 12 plus have been given a 3rd dose or a booster dose. So looking at what happened, and here I can't cover everything, but I'm going to focus sort of on some key sort of public health and health system responses that might sort of explain why the UK has fared relatively poorly during the COVID pandemic. So essentially one big issue is there was no effective test, trace and isolate system for essentially the first year of the pandemic. And this initially stemmed from, like we saw in the US, a lack of capacity. We didn't have enough laboratories, we didn't have enough public health workers to do the testing. And this was because public health for the last decade has seen a huge underinvestment. And there was a big reorganization of public health in 2012, which sort of switched responsibilities, and that sort of led to a huge loss of institutional knowledge, and the public health workforce was essentially decimated. And this led to a decision, the lack of capacity, that on the 12th of March, community testing was paused. And this meant that only people really that were going into hospital, for example, could be tested. Most people wouldn't be able to tell if they had COVID or not. And that led to huge spread in the community. And then it wasn't until the 28th of May that the national test and trace system in England was launched. However, as you can see in the second sort of oval purple, a parliamentary report released in 2021 in October said that for at least the first year and a half, this test and trace system didn't meet its objectives. It didn't have a high enough turnaround in terms of test times. It didn't contact trace enough people. And this was despite it being incredibly expensive. It had a budget of £37 billion over 2 years. That's about a fifth of 1 year of the NHS budget. And the reasons it didn't do so well, I think it was highly centralised. It didn't make use of sort of many laboratories across the country, and it didn't adequately involve local public health teams. It was also overly reliant on public contractors and untrained contact tracers. And at the same time, there were sort of insufficient data systems, both to sort of collect and store the data, but also to share it with the local public health teams. However, I should add that test and trace capabilities are now among the largest in Europe. And you also might think that we took a more sort of laissez-faire style approach to the pandemic, but we didn't. We actually had really strict public health measures in place. So physical distancing measures, we had face masks, we had bans on household mixing, we had no large gatherings, although we didn't have border closures, which could have been key. However, we did have 23rd of March, we had a big UK national lockdown that lasted for a couple of months. Then we had further lockdowns. However, there was a problem that these were often implemented late and sort of after scientists said they should be introduced. The first one can be explained. We just didn't have the data. We didn't have the testing capacity, so we didn't really know how far the virus had spread through the country. However, there were other issues. There was a lack of learning from other countries that had been hit before us and hit worse. There's also the challenge of trying to protect the economy versus trying to suppress the virus, which is often a false dichotomy. And then the response was very much focused on protecting the NHS rather than protecting public health and trying to reduce transmission. And there's also concern over whether the public would actually comply to these measures. However, that was largely misplaced because compliance was actually pretty high for the first year. However, it has slowly been undermined for different reasons. One of those reasons was sort of the diverging rules between the UK nations. Also, England decided for about 6 months to move to regional restrictions. This created mass confusion over the rules and what was in place where. Rules also changed quite frequently, so people didn't know what rules they had to follow. Fatigue, which is sort of natural, people wanted to sort of just live as normally as possible. And there's also been an issue of declining trust in government, and that sort of, there's been quite a few examples of the government themselves being shown to break their own rules, which really has not played well with the public. But just to say, the vaccine programme, this has been an area of success, and this really has been successful, not just because of actions during the pandemic, but also long-term planning. So since at least 2016, there's been a huge investment in research and development and manufacturing, building up manufacturing capacity for vaccines against coronaviruses. During the pandemic, a cross-sectoral vaccine task force was established, and I think this was a real masterstroke, really. It brought together sort of people from the Department of Business that were in charge of purchasing vaccines, coming up with purchasing agreements, the people from the health sector and other actors that were responsible for the vaccine rollout. We had early purchasing agreements were put into place, manufacturing capacity was built up very, very quickly. And also the regulatory agency sort of put in a rolling review process. Instead of sort of clinical trial data having to come at the end of a clinical trial, it could be submitted on a rolling review process. And then the rollout itself also made good use of existing NHS resources. And also it helps, the vaccine hesitancy is quite low in the UK actually compared to other countries, although it still does exist in pockets of the population. And there are inequalities in uptake, particularly in deprived areas and for certain ethnic minority groups. And I'm not going to talk much about this slide because I'm running out of time, but just to say the NHS sort of entered the pandemic in quite a fragile state compared to other countries. We had had chronic health workforce shortages for about 10 years. Bed capacity was quite low, but despite that, really innovative solutions put in place to sort of expand workforce capacity, to reorganize care and expand care capacity as well. However, the big problem is these have sort of exacerbated our existing challenges. So going forward, we're going to see big issues with the recruitment and retention of health and social care staff. The figure on the left from the Nuffield Trust shows that treatment waiting lists have now reached 6 million, which is the biggest it's ever been. So they're going to be sort of big challenges going forward. So what can we learn from the UK experience? So we can learn a lot, but just to pick up 4 sort of key lessons to try and improve health system preparedness and resilience for the next shock. Governance. Governance is key through a public health crisis. So we need to ensure we have effective and transparent leadership, and a clear and timely intergovernmental response strategy needs to be developed right at the beginning of the crisis. This needs to sort of take into account the specific aspects of a pandemic, and this sort of recognizes that a health sector can't deal with a public health pandemic by itself. It has to bring in other sectors as well. And communication matters. Every decision has to be communicated well and transparently to the public. Secondly, in the area of public health, the UK response was really hampered by the underinvestment in public health over about 10 years. If you want to respond well to an emergency public health situation, you have to have long-term investment to strengthen the capacity and capabilities of public health, particularly at the regional level. The health workforce, you have to make sure that you have sufficient numbers, you have to have the right people for the right jobs, and you need to make sure that your health workers are protected and supported. This is all the time, not just in a pandemic, but this is sort of a long-term policy goal. And then finally, for health service delivery, we need to invest in infrastructure. We need to continue developing innovative solutions to care delivery, many of which have actually emerged out of the pandemic. I think I particularly would highlight sort of the use of digital health tools. They've really come to the forefront during the pandemic and should really be built upon as we go forward. And finally, we really need to address inequalities to help build a more resilient society. And I think that's sort of one issue that the UK is facing that needs to be addressed quite quickly over the next few years. So I will leave it there, but more sources for information can be seen on this last slide.
Thank you, Gemma, and thanks for posting some of your publications, books, reports, and papers that folks can read to learn more. And thank you for an excellent overview. Again, a lot of information in a short time. Well, we're really grateful to hear your insights, and thank you for sharing your time with us today. We'll share resources with folks who've attended. And, we're really grateful, and we hope that the next year we won't have to have such a webinar, but it'll be a bit more on a topic of perhaps workforce investments and strengthening in our countries.
Love to come to Toronto, but not in February.
Yeah, and we'll have an in-person session in the summertime.
In the summer, yes.
Thank you so much. And Monica's posted our page where you can see future events. Thank you again for your attendance, and thank you for joining us today. Have a great day. Stay safe. Bye.
Bye, everybody.